It turns out that what many assume about culture in mental health care, that it's just about learning a checklist of cultural traits or customs, is completely backwards.
Really? That's wild. I mean, I always thought culture was about knowing the basics, like customs, language, maybe some traditions. But you're saying it's way more complex than that?
Exactly. Culture is actually a dynamic relational process, deeply intertwined with power, history, and social structures. And if we oversimplify it, we risk stereotyping, othering, and perpetuating systemic inequities, especially for Indigenous peoples and immigrant populations in Canada.
Wow, that really raises the stakes. So this isn't just academic. It affects real people's health, their access to care, even their survival.
Absolutely. And by the end of this episode, listeners will understand why frameworks like cultural safety and violence-informed care are essential. They move beyond the old idea of cultural competence and reshape psychiatric mental health nursing to address structural violence and promote equity.
That's a big shift. So let's start with the basics. How should we really think about culture in this context?
Well, culture isn't a static set of traits or a fixed identity. It's relational and ever-changing. It's co-created in interactions, especially in the nurse-patient relationship. Both nurses and patients bring their own cultural backgrounds, shaped by history, social location, and professional roles.
So culture is happening in the encounter itself, not something outside of it?
Exactly. And in Canada, the dominant culture, rooted in Western Eurocentric values, permeates healthcare systems and shapes assumptions about mental health, often invisibly.
Right, and that dominant culture isn't monolithic, but it influences power relations and social positioning, often marginalizing Indigenous and racialized peoples.
Yes, and that's a key point. Culture isn't just about difference, it's about power. The dominant culture sets norms that can marginalize others.
That makes me think about how traditional nursing theories approached culture. Madeline Leininger's transcultural nursing theory was foundational, right?
Yes, Leininger introduced concepts like cultural competence, cultural sensitivity, and cultural diversity, emphasizing awareness of difference.
But cultural competence often stops at recognizing difference and risks stereotyping, treating culture like a checklist rather than a complex lived experience.
Exactly. And ethnocentrism, the unconscious belief in the superiority of one's own culture, can undermine care and perpetuate othering.
That's where cultural safety comes in, right? Developed by Maori nurse Ramsden, it explicitly addresses power imbalances, racism, and structural inequities in healthcare.
Yes, cultural safety shifts the focus from fixing the patient's culture to transforming the culture of healthcare itself.
And cultural humility complements this by encouraging ongoing self-reflection and recognition of the limits of one's cultural knowledge.
Right, it's about being curious and respectful, acknowledging that culture is dynamic and we can only know what someone chooses to share.
Trauma and violence-informed care, or TVIC, also plays a crucial role here. It recognizes the pervasive impact of trauma and structural violence on mental health.
Yes, TVIC insists on creating safe, collaborative, and strength-based care environments. It's about understanding trauma's ongoing effects, not just past events.
So when we look through a critical cultural lens, we move beyond individual differences to examine how power operates through policies, systems, and institutional practices.
Exactly. Healthcare culture itself can be a barrier, often inflexible and unresponsive to diverse needs, especially for Indigenous peoples who face systemic racism.
The tragic deaths of Joyce Echaquan and Brian Sinclair are stark examples of Indigenous-specific racism and structural violence in Canadian hospitals.
Yes, and Jordan's principle is a legal response to structural violence, mandating equitable access to services for First Nations children without bureaucratic delays.
Structural violence is embedded in political and economic systems, denying basic needs and causing harm through systemic discrimination.
That's right, and when we talk about Indigenous mental health, these historical and ongoing forces are central.
Colonialism, including the Indian Act, residential schools, forced assimilation, and systemic racism, has created intergenerational trauma.
This trauma manifests in higher rates of PTSD, depression, substance use, suicide, and social dislocation among Indigenous peoples.
Yet, Indigenous peoples also demonstrate remarkable resilience and strength through cultural continuity, language, traditional knowledge, connection to land and community.
The First Nations Mental Wellness Continuum Framework defines mental wellness as a balance of mental, physical, spiritual, and emotional health, reflecting a holistic Indigenous worldview.
And the concept of two-eyed seeing encourages integrating Indigenous and Western knowledge systems to enhance mental health care.
Exactly. Programs like Bigajiskan embody this approach, combining elder-guided psychiatry and traditional healing with hospital-based mental health care.
Indigenous women face disproportionate violence and marginalization, linked to systemic inequities and structural violence.
Yes, and that underscores the need for culturally safe, trauma-informed interventions that address these complex realities.
Shifting gears a bit, immigrant and refugee mental health is also complex and variable.
Definitely. Mental health outcomes vary widely depending on immigration status, trauma exposure, and length of time in Canada.
Refugees often have higher rates of PTSD, anxiety, and depression, especially those detained upon arrival.
Immigrants may initially report lower rates of mental illness, but face risks of deteriorating health over time due to social determinants like income inequality, discrimination, and barriers to care.
Barriers include stigma, language and communication challenges, lack of culturally safe services, and misdiagnosis due to culturally inappropriate diagnostic tools.
Social determinants such as food insecurity, caregiver burden, and exposure to violence disproportionately affect these populations.
Stigma around mental illness remains a major barrier to care, contributing to marginalization and poorer health outcomes.
People with mental illness have higher rates of cardiovascular disease and stroke, linked to factors like medication side effects, lifestyle, and fragmented care.
Healthcare provider stigma can negatively affect treatment quality and recovery prospects.
Anti-stigma initiatives, like the Mental Health Commission of Canada's online programs, show promise in reducing provider stigma.
Misdiagnosis is common when cultural expressions of distress differ from Western diagnostic criteria, like somatization or culturally specific syndromes, such as ghost sickness or ataque de nervios.
Understanding idioms of distress and cultural narratives is essential to avoid pathologizing culturally normative behaviors.
So what does all this mean for psychiatric mental health nursing practice?
Relational inquiry is key. Building trust through respectful, non-judgmental engagement that acknowledges the patient's cultural context and lived experience.
Nurses must reflect on their own cultural assumptions and biases to avoid stereotyping and ethnocentrism.
Communication strategies include using professional interpreters, avoiding jargon, and asking open-ended questions about cultural identity, healing practices, and social supports.
Recognizing the importance of family and community in collectivist cultures is crucial, as it may influence decision-making and care preferences.
Incorporating trauma and violence-informed care principles means assuming trauma is universal, creating safe environments, fostering choice and collaboration, and building on strengths.
And nurses need to advocate for systemic change to address structural barriers and promote equity-oriented healthcare.
To sum up, culture in mental health nursing is not a box to check, but a complex, dynamic, and relational process deeply embedded in power and history.
Moving from cultural competence to cultural safety and trauma-informed care is essential to dismantle systemic inequities and improve outcomes for Indigenous peoples and diverse populations.
Nurses are uniquely positioned to lead this transformation through reflective practice, relational inquiry, and advocacy.
So it's worth asking ourselves, how do our own cultural assumptions shape our practice? How can we engage authentically with patients, worldviews, and what systemic changes are needed to create truly equitable mental health care?
Exactly. Those are the questions that can guide us toward better care and justice in mental health nursing.